So we're at the point of developing clinical initiatives. And as you can imagine, what you should do always when you build clinical initiatives is lock all the doctors in a room with a blank sheet of paper and tell them to make it all up. No, that's not what you do. The good news is that you have organizations like these up here, like Advocate, you've got CMS, you've got the core measures, you've got surveys that are done by organizations like the Advisory Board that can give you a good comparative basis to look at what existing organizations have done, what are the good, well-established metrics that are out there, and how can you apply those to your organization. Sometimes people will think in clinical integration that the challenge is the computer system or the challenge is finding clinical measures. That's not the challenge. Those things are all out there and pretty readily available. The challenge is the hard work of engaging doctors. But on that point, to the panel, how do you engage your doctors if you're not going to lock them in a room and give them a blank sheet of paper? How do you engage your doctors around developing, embracing the development of these clinical measures? And how do you make sure that you apply measures to each and every specialty on whose behalf you want to negotiate? We'll start at the other end this time. Travis and Lloyd.
I'd say it's important to choose those physician champions, not so much based off of specialty, but those that are going to engage the medical staff and the community based off of metrics that you think are challenging or the ones that you think are going to make the most impact on your network. So once you engage those, guys, we actually created one of those 6 committees, the care management side. It was actually a clinical guidelines committee. And roughly there's 5 or 6 positions in there, very engaged, very go-getters, and it's always going to be that rule of 20% that's doing 80% of the work. And having them to be able to go out to the medical staff, work on those metrics, and not just work off the metrics that they think are going to be easy to improve, because as you all know, clinical integration is hard work. So it's choosing those metrics that are more meaningful to the network. And when I say meaningful, it needs to be the discussion around what's meaningful to the employer, what's meaningful to the medical staff, meaningful to the payer, because you want to have that discussion as well. So when you're looking at those 5 to 10 metrics per specialty, you need to take all of that into consideration, as well as you need to be able to pull that data and have an infrastructure in place that can easily capture that electronically. Because at the end of the day, you don't want to have them finally get a consensus around a metric that you can pull via paper. So keeping all those balls in motion is difficult and daunting when you put all that together.
Mac and Judy, let me ask you a question about balancing between trying to innovate and do things that are unique and meaningful to physicians, and those things that are more easily collectible.
Well, that was a hot topic for us. I think part of what shaped us around what we first wanted to focus on was our goal of presenting as information to the FTC. And so that sort of gave us some structure around which we had to focus a little bit, as you've sort of indicated in some of the questions, that for every specialty represented in the network or the potential network, that we had identified some finite amount of measures to do that. There was a lot of excitement about, I've always wanted to do this, oh great, this is an opportunity. And then when you really pushed it beyond just the conceptual stage of always asking, and do we have the ability to measure that? What are you measuring? By giving some structure around that, you could lead that physician's ideas to something that is meaningful and is useful and can be measured. I think we are now in the first phases of just collecting what basically we can get out of our practice management systems, which is a lot of the PQRS measures. And we certainly, because that was the first thing we sort of stuck our toes in the water with, we didn't want to imply that that's the only thing that we wanted to do. So we did have some custom measures that we've done. One particularly is around frail hip fractures and looking at setting a goal of door to OR within 24 hours that we knew would reduce length of stay, decreased negative outcomes, and so on. And while that one is one that was very much a custom measure, we are making progress in how do you measure that and collecting that information. So it hasn't necessarily taken away from the more simple approaches of pulling something off of a claims database.
Speaking of claims databases, how many of your organizations are using an EMR as your data collection tool for clinical integration?
Not solely for us.
How many of your organizations have, I think a lot of times the assumption is that you need to have an EMR in each office in order to accomplish this. And I guess this is a pretty articulate reminder that you start where you're at today. Physicians, generally there is data that's available. It's maybe not the best, most clinically satisfying data, but it's good data on physician performance that resides within practice management systems. Start where you're at. Don't wait until each and every practice gets up and running on an EMR. Now let me ask you this, how many of your organizations have used adoption of an electronic medical record, either within the hospital or in a practice, as part of your program? So you're encouraging it as part of your program. All of them. So there you have it. I mean, that's the kind of thing you want. You want to use your program to encourage it, to facilitate that, but you don't want to wait until it happens, because if you wait until it happens, then you'll never be able to go to market. You'll never be able to engage payers around this. And you'll take what should be an ability for physicians to get value for a new product that they're developing out in the market, and you're devolving it into a simple technology adoption initiative, and you don't want it to be that. You want it to be something where your physicians are going out there to saying, look, we're encouraging our doctors to do this, but we need an economic incentive to do that.
Can I give you a plug on that?
Sure.
So, when we initially started our IPHE plan, we were under the assumption that we were going to need to get everybody on EMR, link everybody to EMR, then go to payers and say, see, we are clinically integrated. And had we gone that route, I firmly believe that we would still be struggling and fighting, and I know that neither one of us would be sitting here on this panel sharing our experiences. It was Hogan and Marin, and specifically Tom, who came to us and said, no. This is the formula we're going to use. We're going to use EMR as an endpoint. We're going to build off of what you've already done, but don't let that, because that's daunting, that's discouraging, and the questions that come up from independent practitioners are, how much is it going to cost me? It's not worth it to me. I'm going to be retiring in 5 years. Why should I be doing it now? You've heard them. So I would just say that it was your expert advice that got us on the right pathway.
Thank you.
Tom, I think it's this question of clinical initiatives, what you choose, how you roll them out, what kind of priority you give them, almost goes back to the first question of the day of
Sure.
consensus for your physicians and your health system partners. The physicians are going to come in and they're going to want to cure cancer with this organization in the first month, and you want that sort of enthusiasm. You want this, let's go out and do really cool things. But the problem is the infrastructure to do that isn't in place yet. So you really have to kind of walk before you can run. And so you have to kind of play this balancing act of, yeah, we're not going to just be measuring your compliance with skip measures. We're going to put some stuff in there that's innovative and different. But you do too much of that, and then you're not going to be successful. On the health system side, they're going to say, well, put everything in there related to cost, and just save us a whole bunch of money, and forget about those, quality initiatives that are going to take a long time to have a return. And so you've got to kind of balance that as well. Just one more thing. It's interesting. I came to this meeting yesterday from Washington, where I'd sat on a panel with a group of HIT folks, and the topic of the panel discussion was, what are the HIT needs for a ACO. There's that term again. But again, and you know, the truth of the matter is, again, one of the rate limiting steps in this clinical initiative choice is, again, what are the system capabilities out there that you can use? And as Tom says, don't expect to you know, go out and buy an off-the-shelf system that will allow you to measure every clinical process day one. Those just don't exist. And what you're going to have to do is maybe even start with you know, some things that you're hand measuring and doing in a very old-fashioned way. I remember Advocate, when they started, were using Excel spreadsheets and milk cartons. But you can do it. You can cobble together systems, and hopefully our IT folks will catch up with our needs here pretty soon and give us the systems that we want.
Matt, why don't you talk about, and Chuck, you can talk about sort of what you're doing as an initiative or as part of a benefit of your program to the physicians in terms of electronic medical record.
Well, just a couple things. One thing I want to clarify in this is because when we were using this methodology, I always got very confused about the developing CI initiatives, because what we were doing essentially was identifying CI metrics, right? So we spent a lot of time developing metrics, and we've done that. Now we're in the process of being able to collect the values on those metrics, and once we know where we stand as a network, we're going to use that data to drive which initiatives we implement. So we're taking I don't know if it's a slightly different approach, but we know what we think is important. We don't know how we perform yet, and we want the data to drive which initiatives we implement. So I don't know if that changes your bar chart sequencing, but that's kind of the process we're using. We are using IT as one of our CI programs to get doctors integrated. We offer a full EMR, subsidized as much as possible, and then we also offer a physician portal solution, which is kind of an EMR light. It's meaningful use certified, so we're able to offer it's Relay Health. It comes with a registry, it comes with e-prescribing, light order entry. Doctors can get their $18,000, and it's only costing them about $400 a year, and it allows us to create that HIE and pass information back and forth. Right now, we're able to push out lab results and radiology results. Before the end of the year, we'll be able to push out discharge information, and then starting next year, we'll be passing CCD information back and forth between the medical group and the privates and the hospitals using that infrastructure. And it'll connect to any EMR a doctor already has, so they can be on whatever EMR they have. I don't want to switch a doctor out of an EMR if they've already made that decision and they've done it. You know, love it, keep it, and I'll just connect to it. And this technology is allowing us to do that.
Because the fact is that any EMR you get off the shelf today is probably not going to have a ready-made tool that collects data from multiple practices along particular metrics or initiatives or however you want to divide them up. So even if you had an electronic medical record across practices, there'd be no guarantee that you'd be able to collect data in a succinct way on physician performance. We have a question right here.
It's actually a question about building the organization in CI. And I heard a little bit about this earlier. When you go out to individual practices, you will find everything from smoothly running practices to rat's nests. And I'd like to hear your different experiences, because you're going to have to work with that office staff, especially if they don't have an electronic medical record. What has been different practices or different solutions you've introduced to help these individual practices be able to function appropriately and input the CI data from an individual practice office?
So you start with just an example, something relatively simple like, okay, we're going to measure how frequently you check hemoglobin A1C on your diabetic patients. And again, the physicians go to the meeting and they hear about that initiative and they say, that's great, we're going to go do this. And then they get to the office and it's like, I have no idea how to make that happen reliably every time. So we send this support team that we have out, they literally do a value stream process map of the physician practice process. And if you can imagine just, okay, how do you identify when a patient is a diabetic that you're seeing in that practice? If you do identify that they're a diabetic, how do you document that the hemoglobin A1C was checked? Those sort of simple process things that, again, physicians just aren't very good about thinking about how to set that up. And we have found that, you know, it's kind of like the foundation that you've got to build, the blocking and tackling that you've got to provide training for in your network before you can really run off and do wondrous, more kind of exciting stuff.
And just to elaborate on that a little bit, I absolutely agree with you. Don't assume anything about what a practice really is, because in the analogy that Mac used, not only do the physicians don't even know if they've done hemoglobin A1Cs, they don't have a clue who their diabetics are. And the practice wasn't necessarily able to identify of your patient panel who are diabetics. So as we begin to implement the data collection process for the clinical indicators that we have initially established to sort of determine our baselines, we begin to see that we need many more resources to help support the infrastructure of those practices that are part of our networks, particularly our primary care, because as again Mike indicated, that we see as the foundation of our network. So we've actually wrote a grant to the Duke Endowment, and recently have been notified that we've got our $3 million request funded that's going to help us look at 3 different things. One is to expand and embed within our primary care practices additional staff to support care management and clinical coordination. Also to move our practices toward NCQA accredited patient-centered medical homes. But one of the first steps of that is to actually bring resources in that help those physician practices look at efficiency and utilization of their resources. So they're literally redesigning how those practices function. And we see that as a key component of building a very strong infrastructure and network. So without those building blocks in place and that strong foundation, we can measure all we want, but we really aren't going to get at the efficiencies that we know those physician practices need, and then begin to build on the quality and the patient-centeredness and the better diabetic management and the more patient-centric medical home models. So we're trying to find any kind of dollars we can to leverage those activities. It also includes a rollout of offering to our practices that are part of our network an EMR and the support services that go with that, linking them back to our hospital system so that we can maximize the IT piece of this too.
Now, we're hearing that you're looking at hospital-based sort of initiatives or things that build on what the hospital needs to do to become more efficient, higher quality. You're talking about things that can take place in an office practice to measure certain metrics around quality and efficiency. What I'd also like you guys to talk about is, to what extent are you looking towards what payers and employers would want from a clinical integration program from your network of doctors?
Yeah, well, you know, in short, a successful clinical integration program is going to deliver value into the marketplace, and every payer has their own idea of what value, how value is defined. I think, you know, you can review the literature, and we all have certain concepts of what we ought to improve, but when we've talked to various employers, they come in convinced that they're spending too much money in medical oncology radiation therapy. So they want to see you do something about medical oncology radiation therapy. If you're going to engage with that payer, then you've got to hear how they're defining value. And in the end, they're going to drive the metrics, just like CMS with their publication. You know, I think the current Guinness Book of available clinical metrics, I think, totals about 800 now. And, you know, so when we went into this program, I just want to add a couple of comments that I thought about from the previous slide, and that is, when you make these selections as to which performance measures you're going to use, understand again from the physician mindset, the 2 things that'll jump out of a doc when you select the measure is its attribution potential. Is it really measuring me, or is it measuring a process? And the second thing is the benchmark you choose to measure it against. has to be a meaningful one. And that very much helps in the selection process because there are just a ton of metrics out there that you can choose. When we go out proactively now and talk to payers, we talk about the clinical initiatives as opposed to the quality that we're currently offering that may or may not be applicable. Because in the end, you want the payer to support the infrastructure up front in some sort of payment reform. You know,
Bingo.
clinical delivery reform can't occur unless you got payment reform to help fund it because, you know, living in the fee-for-service world, none of this care coordination stuff is paid for. So you've got to engage the payer in that conversation as to what does value mean to them. Is that getting it?
That's definitely, and I think it also speaks to the fact that you don't need to be shy about talking, you know, as long as you have enough under the hood to go to the payer, don't be shy about engaging them throughout the process. You don't need to wait to build something and then go out to see them because you're afraid. Go out and engage with them up front. And I think that's something that Rick, you've done.
Yeah, we started from the beginning of our process, we started talking with the payers. And because of our community, we also started talking with the employers. And I got to tell you, school systems are great places to start. Because the school systems are always looking for a way to try to control their costs. I've talked in front of insurance committees and school systems with the union representatives right there about what a CI program can do and can bring to them. I personally believe if you can in your market, you start with the employer. The payer, you need the payer at the table. You got to work with the payer. The payer wants you to reduce ER, reduce readmissions, cut down on your multiple CTs and MRIs. That's what they want you to do. And if you could do something on drugs, do something on drugs. The employer actually cares about their employee base and how do you help lower my overall cost of my healthcare dollar. And that starts with, and I think Lloyd touched on this earlier, using your own employee base as your guide and creating a baseline, showing what you can do for your employee base and what you've done for your employee base, and start showing that data to employers. That's the stage we are just at, is looking at our own employees and then being able to take that out and show employers. They can bring any payer to the table or any TPA to the table that they want. I believe if you, and again, it depends on your market. If you can in your market, working with the employers directly is a great way to go.
And I would support that so that there's no confusion. I included payers, employers in the payer category because that's pretty much where our conversations have occurred directly with employers. I agree 100% with the comments about we know what the payers.
Well, in fact, your payers generally might not be enthusiastic about physicians coming together and collectively negotiating with them. And historically, they've done a good job of selling their value proposition to their employer customers as we're great at ratcheting down on unit price. Now, employers, it started to dawn on them, I think, since healthcare reform especially, that in that 20 years that they've done a great job of reducing the unit price that they pay physicians and hospitals, that costs have only gone up. And so to really try to engage payers, the key is to talk to the employers. And that's something that the Advocate Value Report does a great job of. It's written specifically to talk to employer concerns. And so if you want to try to engage the payer, make sure you're talking to your local employers, which are in many cases people that your hospital is working with in the community. They may be on your governance boards. They may be people that you know, from a business standpoint, engage those prominent business leaders to get their feedback into what they would like to see in your program.
When you're going out and talking to the physicians, especially those who are physicians, make sure that they understand that when you pick the initiatives, you're not picking things that you're already good at. Because the whole idea is to be able to show improvement. And if you're already getting 96 to 100% of these things, you can't show you've gotten any better. And that's hard for physicians to willingly select things that they may kind of stink at initially. But I think it's important to make sure that you're getting things that you actually show improvement.
That goes back to that definition we talked about earlier. You know, you always have to answer the question, that third part of that test, why is joint contracting reasonably necessary? If you're picking something that you're really good at right now and saying abracadabra, we're clinically integrated, you're not able to answer the question, why do you need joint contracting in order to achieve this efficiency? What you're always trying to say is that we as a physician community need the incentive of joint contracting in order to get to that next level. And so you need to find those initiatives, measures, metrics, whatever, that you can improve on. You can't simply say, hey, we're great, ergo we're clinically integrated. It means we're committed to a process of improvement. We're willing to be accountable to that process, so that's what we're going to measure it. But the most important thing is that we're actually doing something to improve. Now, in terms of the infrastructure, oh, no, go ahead, Chuck.
I just wanted to add a comment to the guy who asked the question about the structure and going out to the variable practices. You never know what you're going to find. The one thing we found almost consistently, regardless of the sophistication of the practice or its appearance, is that virtually 100% of the docs who agreed to sign up for the program forgot to tell anybody in the office what they were doing.
Same thing.
So,
That's right.
so, you know, learn from that experience. You go out and they have no idea what you're talking about in terms of what they've got to hook up connectivity and get access to their claims, so it becomes an entire new re-education process. And for the physician practices, remember, you know, we were talking before about remediation and weeding the garden. You know, sometimes what you've established as expectations for membership are self-selective to some practices. They don't want to make that step once they hear about it. So I think in the end, the clinically integrated, you're not going to recruit everybody. The clinically integrated network will be better off with a practice and a culture that doesn't see the vision of, you know, making the changes in order to access current pay-for-performance dollars, e-prescribing dollars, and move into the electronic world. But we offer everything that we've heard here. You know, you got to go out and work with the offices. Offering them an EMR that has 2 vendor support visits that goes along with the purchase doesn't really carry a practice into the IT world. So our people are out helping the office. You try to help them with, what's the term I want, patient flow redesign, even in the practices, trying to share learnings there as well to make them more efficient and more productive.
If I can piggyback on what you said, you know, one of the things about initiatives that we're thinking about for us is access. And you know, we're going to make access a huge part of our network, whether it's an initiative that we measure or a requirement for membership in the network. I mean, you ask your patients, what's the #1 priority that they have? Better access to telephone. It may be that some of the practices that you deal with, and certainly we're not going to be different, their offices are going to need some education on how to schedule patients better, whether it's block scheduling or holding so many spots open per day for same days, whatever it is. But that's, you know, you may have to go out and do some tutoring of some practices who are kind of dysfunctional. They're going to be in your network. They need to learn how to function better.
When you're talking cost initiatives, and this may be real obvious to everybody, but it really wasn't to me when I started this, you really have to think, whose costs are you trying to affect? And one of the problems with this employer versus payer situation is many, many times the payer's costs are not the things that you're affecting. They're the employer's cost. And the payer is serving as a third-party administrator to that self-insured employer. And so you can talk to them all day long about a value proposition, about driving down costs, but the truth of the matter is they're processing claims on a per-click basis, and they don't care. So I think it is important, as somebody said, to get to the people whose costs you're really affecting and get beyond those people who, again, just, you know, business as usual is great because the more clicks, the more money we make.
Now, we have a question here. Yeah.
Yeah, I want to take that a little further as far as access. You know, Advocate, what I heard yesterday was Advocate just now is starting to put case managers in the primary doctor's offices. And it's taken them a few years to do that. So for you guys up there, you know, for myself, I look and I say, yeah, the medical home model or something like that, we're going to have to be there. Where and when are you guys starting to introduce that for your primaries?
We actually are going through patient-centered medical home process for our practices that are going to be accredited. So for us, it's 15 practices. So we see that in parallel to our clinical integration efforts. We're also actively engaging infrastructure in the clinical integration model around care management. So we're beginning to have care management discussions with the employers along with the payers. The payers are willing to carve that section out for employers. If not, educating both sides so that even the payers have identified in our market that we as a network can do care management better than the payers do when they split it up across just the population they cover. So, I think we talk about employer versus payer, or is it payer first then employer? We've been doing both, and Rick can talk about the school consortiums. In our community, we have the first of its kind in New York City, or New York State actually, which is a municipality consortium. So this is where all the municipalities that were acting as cells have come together, they pool their risk, they act as a single Article 47 health consortium across municipalities. And they've actually asked the community of self-insured to come to the table and begin to talk about meaningful programs, begin to talk about patient-centered out of the home. So it's the employers that are actually engaging us saying, what's clinical integration, what can we do for us?
Now, on that, certainly care management is something that's extra to clinical integration. But it's something that you found in your discussions, I think, with Cornell as a payer, that was something that was seen as valuable and something that you made a conscious decision as part of your clinical integration design to incorporate care management right up front, not wait to do care management down the road, but actually just to build it right into your process from the beginning.
Yeah, it's in our current pro forma now, part of our infrastructure, and we're going to be coming out of the gate with care management.
Care management was one of our committees that we identified right up front that we need to involve. We just thought it was the right thing to do for the community and the right thing to do for the physicians as well. I mean, how many times do you as a physician need a service and you have no idea even how to get it? To build that right into the program from the start, and I think it's a selling point with docs who are a little bit skeptical in terms of even just building consensus.
And something you found that you could an expense you found that you could bear because the employers in your community were interested in buying it.
But again, Tom, follow the cost. And what we found in terms of our care management program, which Judy was instrumental in setting up, is who's going to benefit from that, and whose costs are going to go down if you put that into place. First place we looked was, again, ourselves, our own health system. So all these patients that cycle in and out of the hospital because they're unfunded and they don't have primary care physicians and they don't have follow-up after discharge, those patients, their costs are borne by the health system itself. So we got some grant funding from our own system to help set up this aggressive care management program for those high-risk patients. Medicaid, again, a big problem with them is, again, access of their patients, keeping them out of the emergency department, keeping them out of the hospital, and again, they're interested in that, especially the Medicaid MCOs have been willing to fund this. So think about it as whose costs are you affecting, and follow those dollars, and I think that's where you'll get funding for this sort of stuff.
And that raises the topic of infrastructure. And basically, when you are looking for an infrastructure, again, we said don't start with an EMR, but one way or another, you do need to collect data from about physician performance from the inpatient standpoint and from the ambulatory side. That means you're going to have to identify some system that's probably not existing within your health system today that can do that. There are a number of systems that have sponsored ICQV. You can see them at the cocktail party. They provide services like that. I guess what I'd like to talk to the panel about is, in terms of selecting those systems, what was your process to do that? How were you staffing the implementation of those? And sort of what was the process of selection, and how do you engage doctors around that? A lot of different questions, but on the infrastructure side.
We, as I alluded to earlier, we started off with the idea that we were going to get everybody on the same EMR to begin the process of clinical integration. Fortunately, we were set straight, but we still, shopped a bunch of the vendors, and we settled on one that the PHO was going to sponsor and support with, the tech support. We've trained our own people, so we don't have the vendor coming in to take care of problems. Our own people take care of problems. We went from there to evaluating a number of systems that were going to collect the data of the metrics that we decided on. We allowed to give, we decided, should we give names?
You can if you want, but I mean.
All right, so we chose Crimson for a variety of reasons. I think that they came in with the experience as well as the capability to do the claims, they're doing claims data evaluation. And we have, as it's been set up elsewhere, we have a quality initiatives committee that basically is our quality people from the hospital end working on our IPHE. So again, we're not duplicating services. We're already using existing infrastructure to achieve what we wanted to achieve.
And one of the advantages we saw with Crimson, and no Crimson commercial, but we felt it was important to grab data from the ambulatory side. We needed to get it from the physicians, and we needed to get it in a simple way. And we just felt their solution did that. On the inpatient hospital side, we had all kinds of systems that we could pull data on doctors. But this seemed to work because we could pull the data and bring it all in one place, and had the ability to sit with a laptop with a physician and just kind of go through, how they're performing. And if, they said my patients are sicker, we can show them that they either are or aren't. We can pull a patient out. So it's a powerful tool. We just kind of finished going through our data attribution definitions. And that was interesting too, because we just brought that to the board, and the board settled on the policy saying, yeah, that makes sense today. But we know going forward, we're going to have to continue to adjust this. And there's going to be things that pop up that this doesn't meet. So it's all that part of, going back to the very beginning of this meeting, that trust. And everybody understands that going back.
One point I'd like to make about the data, physicians are going to, again, it's already been made a couple times that physicians are skeptical of us collecting their data. But what needs to be pointed out to each and every physician is that United Healthcare already has that data. Blue Cross already has that data. They already have the data and are using it to negotiate against you. What we want to do is collect that data so that we can use it for good, not evil. But we want to use the data to be able to drive healthcare improvements. And, it's not, we don't have a hidden agenda. The data is already being collected somewhere.
We have regular managed care councils with our payers, and Excellus Blue Cross, comes in with our data, and we look at it, and it's mangled. They misinterpret it, and just like Frank said, then they use it to bash you over the head with it. So to get out in front and have control of your own data, and then use it, in a positive way is meaningful. With us, and as Tom alluded to, it was very important for us to build care management into our network. Care management really is the backbone of our clinically integrated network. So in deciding how to do it, there were a couple of options that we were looking at, but we had to be able to build care management into the entire data collection process. And we basically narrowed it down to 2 different systems and have been vetting that with Tom and John's help to decide which one is the best for us. But if you're interested in care management, I think it's important that you get it involved at the ground level when you're deciding how you're going to measure your data.
And I think the important thing is to find a good, capable system that's able to collect ambulatory and inpatient data so that you can measure physician performance and then actually act on it. Because just measuring physician performance isn't clinical integration. It's the physicians holding each other accountable to improving on that information, improving on that performance that you're getting the data about. And, as I said, there's a lot of the different vendors that are here at the conference today. You can talk to them, evaluate their systems, and just make sure that when you evaluate them about how well they can measure physician performance in both environments, and see which one fits best for your environment.
Let me say something about that, Tom. When you're talking to vendors, I like to say, you know, the whole healthcare system is going to a more outcomes-based payment system. And we need to do the same thing with vendors. They need to be held accountable for giving us the outcomes that they promise. And I can't tell you how many icons I've got on my desktop computer at work that, you know, are figments of somebody's demonstration that this could solve the problem. And so, again, don't be fooled by fancy diagrams with pipes leading to tanks and dashboards sitting on top of them.
Because it doesn't actually work
all
that way.
All this data will flow, and you'll be able to instantly analyze your organization. Hold them accountable to that, and make sure you understand whether they can really deliver on these promises, or whether, again, you're just going to be left with a system that's a dusty icon on your desktop.
Also find out whether they've done it before and whether they can put you in contact with organizations that they've worked with specifically in the context of clinical integration, which is different from, you know, a medical home or different from an EMR implementation. Yeah.
Well, can I just have a question to that? Getting the payers to comply, but it has to be done in an enforceable way, doesn't it? I mean, not just in an agreement, but how do you actually enforce that? Because we could pin so much of our success on receiving elements from them, but our experience is that they can be a month late, or they can be 2 months late, or they can not do it or not give you all the data.
I think that's a great point in terms of, have any of you built your systems to depend on getting data from a payer?
We have a couple metrics that are payer data dependent. And so
but not the lion's share.
Not the lion's share. No, the majority of it is provider data driven, but you know, some of those things you just can't get from a provider's data source. So that's something I think you negotiate into the contract with the payer. So we're going to deliver this value, but for us to be able to do it, you need to be providing us a paid claims file every month, and it's got to be in this format, and here's the date of the month I need it, and here's what you're going to pay if you don't deliver it.
And again, if you engage their employer customers up front, you have a good relationship with them, you're more likely to, if you're dependent on that data, you're more likely to get that data from the employer than from the payer. Oftentimes the payer is going to come up, you know, even without bad intentions, they're going to come to the data if it's unstructured or late or not what you were looking for.
And don't be fooled that, I mean, somebody said earlier they've got all this data, and they do, but the dirty little secret is they can't get the information out of all their data any better than you can. And, you know, so don't be fooled that they have all these capabilities. Again, one of the dirty undersides of the whole system is that when you charge a high enough premium, you don't have to do much data analysis to be able to set that price point. And a lot of these companies don't have those capabilities. You think they do, but they don't. So, you know, the data's in there, the claims data is there, but, you know, don't expect them to be able to magically push a button and feed that to you in any sort of really kind of analytical fashion. It just doesn't happen.
And Tom, the only other point I would make is we've talked a lot about the data systems, but don't underestimate the human infrastructure that you need to understand these systems, that know how to get the information out of it, that can vet it, because it goes back to some of the points that were made earlier about data is only as good as the physician trusts and believes the accuracy of it. So I think one area we probably underestimated is the need for those warm bodies on the ground that have a thorough understanding of the data systems and how to drive that information out, how to vet it for accuracy, and how to present it and discuss it with those physicians so that it can be used to drive performance improvement.
Which it sounds like to me what you're also saying is that may not be, that particular skill set may not be present today within the health system. As much the resources you can borrow from a health system, that may be something that you need to get specifically that's new. Okay. We're wearing on. We've talked a lot about engaging payers, and I guess the secret there is don't wait don't get caught in a chicken and egg situation where you feel like you have to be fully up and running data, showing performance before you can even approach the payer market, or that somehow they'll turn you in if they think that this is what you're doing. Go ahead and engage them fairly soon in the process. When you have enough, when you understand what your measures are going to be, when you know what your infrastructure is going to look like, don't hesitate to contact them directly. And we've talked a lot about that. I guess what I want to talk about in terms of that is sort of, some of you have alluded to this, but using the health system's self-funded benefit plan as sort of your first customer, and which seems like a no-brainer, but I guess it's not always the easiest thing. It's surprisingly not the easiest thing to actually get off the ground. Maybe some of you can comment on that.
Well, that was our experience. I mean, you know, this whole concept of your self-insured employees gives you the opportunity to build a learning lab regarding clinical integration or delivering care more accountably. And the internal silos sometimes are more formidable than the ones you find external. Just the way it is, you know. I mean, history had generated a health plan in a medical group after 20 years of full risk involvement in a capitated product that it was a contentious relationship. So they weren't very open to the notion. But ultimately, as system leaders accepted the vision and committed to the vision, that will be our first opportunity, and it's a very desirable one because of what you can learn from it. In the end, whoever wins or loses all comes back to the same bottom line, and so we've designed a respectable funds flow mechanism, which was really the issue is what's going to happen with the money. So once we work that out, everything else seems to be easy. And as we've had these conversations on a bi-weekly basis with the insurers and the other stakeholders, it's helping advance the whole notion of clinical integration and a role it can serve in benefiting, creating win-wins for everyone in the system. So. And
Rick, I think you've found that there's some credibility that you get with your payer discussions when you're willing to do that.
We sat down with the local Blue Cross plan, and we, at the same time we were going through our analysis with our own benefit plan, first question out of their mouth was, can you show me what you've done with your own employees? That's what they were looking for. Mm-hmm. So it's a key piece, and it's become our driving strategy around the payers, is to be able to show what we've done with our employees, bring that out, show the payers, help drive that these are the metrics we measure, this is what we've been able to improve, but it's helping us a great deal in driving these conversations. And we're just in the early stages of our conversations with our payers.
Now, I think there's sometimes an assumption that, or at least, especially since the whole healthcare reform discussion has taken place, that the assumption is that the only thing you're going out to employers or payers seeking is a shared savings contract. And I think the ACO dialogue has gotten to that. But I guess in your experience, what is the variety of sort of proposed payment models that are out there that you'd want to seek?
Tom, I think the one unique way of doing that, and kind of a mindset that we've come to just of late, is to, again, not try to talk to payers, especially early on, about specific transactional arrangements around specific initiatives, but to instead take to the payers a value proposition regarding the entire clinical integration process that you're putting together, and ask them for an upfront investment in that. And I think that that accomplishes two things. One is, I think the value proposition is easier to convey in a kind of a generalized fashion to payers about this kind of new and different model in that fashion. And secondly, again, you don't have to get up into that data analytical gap that I talked about, where, okay, we're going to go to Blue Cross and we're going to save you X amount of dollars by doing less MRI scans for low back pain, but you can't measure how much you paid us for MRI scans for low back pain last year, so how are we going to structure that? Instead, hey, Blue Cross, you give us some upfront money. We've got this group of 500 physicians. We'll align them towards doing some of the things that are costing you a lot of bucks, and you'll get a return on that investment. I think that's a better way to approach payers than kind of this dollar goes for this, and trying to structure these individual initiative things that are very tough to measure.
So in other words, you're trying to say you're bringing to them a different product, something that's new, that's valuable. You're making a good argument that it's valuable,
That's right.
and then you're willing to look to any kind of pricing that will address the value of that model, whether it's the fee schedule or a shared savings or a quality bonus or some other payment.
And if you look at the advanced quality program that we heard about today from Blue Cross Blue Shield in Massachusetts, that's essentially what they've done. They've got some initiatives, no doubt, but it's not like they're tying this dollar to this savings. They're saying, you know, here's the deal, and it's much more.
And I think in our recent discussions with Blue Cross, we've discovered that tying, even though they originally entered the discussion around tying $1 of savings to this particular doctor, that it freaked them out to think that they would have to administer measuring
That's right.
whether a dollar meant that. And they were actually a lot more comfortable with this approach than because their systems couldn't, even though they wanted to talk about shared savings, that their systems couldn't accommodate it.
They can't.
We have a great relationship with Aetna in our area. We have a so-so relationship with Blue Cross Blue Shield. The more docs that I talk to, the more people I talk to from systems around the country over time, the more I find that everybody's experience is different. But there's no doubt that the most successful CI networks that we've encountered have been the ones who have been able to build a really good relationship with their payers. We pitched our network pretty early to our payers. Aetna received it extremely well, and we're very excited about it. We gave this whole presentation to Excellus, which is Blue Cross Blue Shield in our area, and they kind of paused, and their executive VP said, so you could essentially cut us right out of this now, couldn't you? That's the one thing. He didn't focus on care management. He didn't focus on healthier patients. He focused on the fact that we could cut him right out. So they're all going to be a little bit different, and you know, I think how you approach it is certainly going to impact how your network turns out.
Now the other thing you'll find out is, well, Lloyd may be able to work something out with Aetna and get some incentive-based contract. I could go meet with Aetna in Ohio and say, hey, you just did this with these guys over here. We want to do the same thing. They have no concept. They're not passing along information amongst their plans. It's just mind-boggling. Everybody's regional, and you got to really just work with the regional people.
I mean, and that brings up the whole idea of sort of, well, what we found, and all of you, except for, and we're planning on with you guys, we've brought these programs on a voluntary basis to the Federal Trade Commission. And in each and every one of those cases, what the FTC staff, and in fact, that we just brought an organization there on Monday, and the FTC again said this, they were very happy to hear that payer engagement started even before the program was finished. Because in their mind, it was ridiculous to wait until it was all built, because you weren't getting the consumer's input into this. You weren't finding out whether or not you had a product that the market wanted to buy. So they actually like that you engage payers pretty early on. Obviously, you have to have enough under the hood. You can't just go to them with a sketch and say, here, this is what we want to work with. You want to come with some specificity, but you want to engage them as early as you can in the process. Speaking of which, let's go to this as we close. In terms of that process of going to the FTC, you know, to a certain extent, we've gone, you know, some organizations around the country have been very prominently have gotten advisory opinions. We tend not to advise our clients to do that. The advisory opinion process is something the FTC will do. They're willing to look at it, but it must be a business plan only, and you cannot actually be out there in the market doing anything. And it can take them a while to actually review your program. What we normally do, though, because we think that's too lengthy of a process and the market can pass you by, we always try to build into the process engaging with the regulators, the FTC, in many cases, states' attorneys general. From our standpoint as lawyers, we want to do it to sort of be prophylactic, to let the FTC know what you're doing up front, so that if they get a payer complaint, that you can explain, that they can go back to the payer and say, well, what aren't they doing that they said they were going to do? It also gives them the idea that this is a really good, robust program, and as Rich Feinstein said this morning, not the kind of program that they'd be likely to pursue. From a management standpoint, though, I want to talk about the idea of going to the FTC or building that FTC visit into the process. How did that help with, we talked earlier about how you can't have the same meeting over and over. How did that help in moving the process along so that you didn't get stuck at certain stages?
Well,
I was just going to say, for us, it was extremely valuable. It sort of created a timeline or a line in the sand that we needed to have certain things accomplished. And as all things in large, complicated systems, things can get sidetracked and diverted, and some of their emergency or fire puts that on their priority. It really gave us a target to shoot for. And with your guidance and wisdom, we engaged some folks at the corporate level who probably had not been as invested in the day-to-day journey of this, and they came with us to that FTC presentation, and I think it really was eye-opening to them, even though they were folks that we thought were knowledgeable and comfortable with what we were trying to pursue. For example, our corporate counsel, who had been involved with all of this, I think it really clicked for him right as part of that FTC prep, as it did for our CEO and others. So it was very, very helpful for us to have that as a target.
Yeah.
I agree with it being a performance milestone that was very important for our developing program. Some of the more interesting consequences of that visit is that I think it did seal the vision internally for the system, in terms of, we came back and it's like, you guys are really something. You did that.
That was for us too.
It wound up in the media, and for those seeking to develop clinical integration program, first to market should not be ignored. And in the end, Detroit is a highly competitive marketplace. There's only one organization that's had FTC informal rubber stamping of its clinical integration program, and I think that carries us significantly in the marketplace as well, being able to brand ourselves as whatever we can brand ourselves as. FTC applauded our efforts.
Sure. And Rick, was that nice? Was that nice to get there before the Cleveland Clinic?
Yeah, it was absolutely great to get there before the clinic. It's really interesting because it becomes that first thing you tell a payer when you sit down in a conversation, and it changes that whole relationship. Actually helps into the relationship. But I agree with everything that was said. But the kind of really neat thing about it is after you go to the FTC, or even when you're going to the FTC, you kind of look back and you say, wow, we really accomplished something here. Because you lose sight of that as you're working through it and you're doing all these pieces and parts and building this and that. You go there with all this information and you look at it and you're like, wow, we really accomplished something, and this is really a value to our community.
And it's an accomplishment that's important to the physician members to see that it's gone somewhere, we've achieved something. This is one benchmark, one milestone that we're going to build on.
And I guess we'll leave this discussion, and I'll stick around, and I'm sure the panel will stick around afterwards, and even during the cocktail party we can talk about it, any other questions you might have. An article that Larry Castellino, who's one of the foremost experts on clinical integration, he's a physician, used to be at University of Chicago, he's now at Cornell. The FTC's go-to expert in clinical integration, also very influential in the development of the idea of the ACO. This is what he wrote in an article back in 2006 about clinical integration. And it's true today, as it was then. Though creating clinically integrated organizations is difficult and expensive, physicians should recognize that clinical integration can help them both to gain some negotiating leverage with health plans and to improve the quality of care of their patients. And so that difficult and expensive is part of this. It also is, this is something that you can do significant for your community in a way that gets recognized from a payment standpoint. we'll leave it at that. Thank you for your time and attention, and happy to entertain your questions after the session is over, but you know, our time is up. Thank you very much.